Agarwal, medical oncologist and hemato-oncologist from Udaipur, to talk on the topic PHESGO, transform the journey for your HER2 positive breast cancer patients. Over to you, sir.
Thank you. Good afternoon, everyone. So we have just, I think we have preponed the talk by 1 hour. So next 10 to 12 minutes, what we are going to discuss is a new molecule that has come up. It's not exactly a new molecule. It's just the route of administration that has changed. We have been routinely using pertuzumab and trastuzumab as IV infusion. Recently, Roche has launched a subcutaneous preparation by the name PHESGO. So currently, where does PHESGO stand when it is very convenient for every one of us. We've been very used to using IV preparations. So where does PHESGO stand as of now, and what are the advantages of PHESGO when it is compared to the IV preparations? And so we're going to just talk about this product. So a brief introduction about the combination of pertuzumab and trastuzumab. We all know that pertuzumab and trastuzumab combination has led to significant increase in the overall survival when it comes to management of HER2 positive, either metastatic patients or in those patients in which we use these agents as neoadjuvant treatment or adjuvant treatment. So the Neosphere trial. The Neosphere trial had shown that when the combination of pertuzumab and hertuzumab and trastuzumab in IV form, when it was used in neoadjuvant setting, it improved the pathological CR rates from 31 to 49%, and it has shown a significant improvement in, this was quite significant, the improvement in pathological CR rate. Similarly, in the Affinity trial, the adjuvant treatment, when adjuvant treatment was given to these patients, pertuzumab and trastuzumab, it reduced the risk of recurrence of death by 23% as compared to trastuzumab alone or trastuzumab with chemotherapy. And the Cleopatra trial was a trial that was performed in metastatic patients, breast cancer, HER2 positive. The combination of pertuzumab and trastuzumab significantly improved the PFS as well as OS. The median OS was improved by approximately 15 months, quite significant. This shows that the combination of trastuzumab and pertuzumab is currently the first line treatment in those patients who are HER2 positive. So this is the current guideline. Newly diagnosed HER2 positive patients of breast cancer, if the tumor size is more than equal to 2 centimeters, or if they are lymph node positive, if ERPR negative, we go for chemotherapy as neoadjuvant treatment. Along with that, we give pertuzumab and trastuzumab as neoadjuvant therapy. Patient undergoes surgery. If the patient have pathological CR, we continue with pertuzumab and trastuzumab. And if the patient have residual invasive disease, we go for TDM1. If the patient has localized disease, if it is operable, the patient undergoes surgery and adjuvant treatment and decided on the basis of the guidelines that we routinely follow. Pertuzumab combination with trastuzumab is given for lymph node positive disease, and lymph node negative we only go for trastuzumab adjuvant along with chemotherapy depending on the guidelines. So now IV infusion sometimes can be problematic for patients who in the hospital setup, especially when there are a lot of when the patient's load is a lot. It can cause congestion, it can cause increase in the waiting time, challenges related to the venous access and placement and maintenance of indwelling venous catheters can be problematic, and challenges of improving the resource utilization can be problematic. So PHESGO is the first formulation which has combined two monoclonal antibodies, pertuzumab and trastuzumab, in one vial, which is it's a fixed dose combination, which is being used as a subcutaneous route. It contains the same antibodies as approved for IV pertuzumab and trastuzumab, but has a different route of administration. It is formulated with recombinant human hyaluronidase, which allows easy administration by the subcutaneous route of higher drug volume. So the loading dose, it comes as a 15 ml, and then the maintenance dose is a 10 ml dose. It's a ready-to-use fixed drug combination administered by a subcutaneous route in the thigh over approximately 5 to 8 minutes. So how does trastuzumab and pertuzumab combination act? Now basically we all know that pertuzumab basically the combination of pertuzumab and trastuzumab, they are basically a dual HER2 blockade system. They act on HER2 blockade. So in preclinical models, pertuzumab targeted a different subdomain on the HER2 receptor as compared to the trastuzumab, and thus they block the dimerization of HER1 and HER3 receptors and provide a dual blockade of HER2-driven signaling pathways. Now, hyaluronidase is an endoglycosidase used to increase the dispersion and absorption of the co-administered drugs, and when they are administered subcutaneously. Basically, what it does, it degrades the hyaluronan, and thus the drugs can easily disperse into the subcutaneous tissue and then gets absorbed. This is the impact of hyaluronidase, how it acts. So the subcutaneous layer contains a matrix of hyaluronan and collagen fibers, which limits the subcutaneous administration of the drugs to less than 1 ml. But with the addition of hyaluronidase, what it does is temporarily and locally degrades the collagen fibers and hyaluronan at the injection site, with no change in the structure, providing the macromolecules collagen and elastin. And thus, once the hyaluronidase is administered, the structure of the skin, or the structure of the subcutaneous tissue with the collagen fibers, it is restored within 24 to 48 hours. So after subcutaneous administration, the architecture of the skin is reformed within 1 to 2 days due to the rapid clearance of recombinant hyaluronidase and fast hyaluronan turnover. This allows more than 1 ml, at least 15 ml of the drugs to be administered via the subcutaneous route. So where does PHESGO stand as of now when it comes to the pharmacokinetics? So there have been data which has compared the pharmacokinetic properties of a subcutaneous route versus the IV route, and so this was the clinical development program. The recommended doses as of now of PHESGO, the loading dose is 1200 milligram of pertuzumab with 600 milligram of trastuzumab, and then the maintenance dose is 600 mg of pertuzumab and 600 mg of trastuzumab. So the pharmacokinetics data, the efficacy, safety, and preference data that has been shown in 2 trials. First was the Federica trial. It was a phase 3 trial in epithelial breast cancer patients. The primary analysis was in 2019. Then we have the other trial that is still ongoing. The primary analysis was in ESMO 2020. It was presented. Now pharmacokinetics and the dose finding, the data, that it has suggested that it selected a loading dose of 1200 mg of pertuzumab along with a maintenance dose of 600 mg of pertuzumab. The loading dose of trastuzumab and the maintenance dose of trastuzumab are the same, to 600 and 600. Pharmacokinetics data in male healthy volunteers and the patients with early breast cancer, it predicted that these doses will result in an equivalent pertuzumab and serum exposure to that of Perjeta when it was given at a IV dosing of 840 and 420 milligram respectively. So the dose finding processes used to find the subcutaneous dose of pertuzumab was similar to those used successfully in the development of both Herceptin subcutaneous and MabThera subcutaneous forms. In the safety profile, there were no new safety signals observed for subcutaneous pertuzumab alone or when co-mixed with formulations of Herceptin subcutaneously. The pharmacokinetics and the safety results of this trial supported further development of PHESGO. The Federica trial, it was a phase 3 non-inferiority trial which basically assessed the pharmacokinetic properties of subcutaneous pertuzumab and trastuzumab combination in a fixed dose. So the patients who had centrally confirmed operable or locally advanced inflammatory or HER2 positive breast cancer with primary tumor of at least 2 centimeters in size or node positive disease, they were randomized into 2 arms. Both arm A and arm B. Arm A patients received dose dense AC or AC every 3 weekly into 4 cycles, and then they were divided to receive either weekly paclitaxel with IV pertuzumab and trastuzumab, or 3 weekly docetaxel with IV pertuzumab and trastuzumab. The other arm again dose dense AC 4 cycles and AC 3 weekly into 4 cycles were divided into 2 arms. Either they received a fixed dose combination of PHESGO with Pacli every 1 week, or fixed dose combination of PHESGO with docetaxel every 3 weeks. And then these patients underwent surgery. It was a neoadjuvant treatment plan. After the surgery, patients were again either received IV formulations of combination of pertuzumab and trastuzumab, or they received PHESGO for the remaining 42 weeks, and then the patients were followed up. This was a trial that began in June 2018. So the primary endpoint was non-inferiority of cycle 7, the pre-dose cycle 8 trough concentrations of the pertuzumab molecule, and the key secondary endpoints were non-inferiority of the cycle 7 trastuzumab serum trough concentrations. The pathological CR rates were also included as secondary endpoints. The IDFS and the EFS were also included as secondary endpoints. So this was the result. The pharmacokinetic parameters, the results suggested that at the end of the cycle 7 or a pre-dose cycle 8, the trough concentrations of PHESGO versus the IV formulations were the same. This had impact. This was related to the mode of action as well as was associated with clinical outcomes. This also suggested that the fixed dose combination of subcutaneous molecule, the PHESGO, was non-inferior to the IV formulation based on the pre-dose cycle 8 trough concentrations. The pathological CR rates were also quite similar between the two arms, IV preparation versus the subcutaneous preparation, again strongly supporting that the two molecules are the same. Safety profile, there were no new safety concerns except for the injection site reactions. All adverse effects, including the grade 3, were quite similar. Most common adverse effects were balanced between the two arms. The cardiac dysfunction, which is of very important concerns to us when we talk about anti-HER2 treatment, were also similar in terms of incidence and prevalence rates. There was no difference in the cardiac safety profile when it comes to both the molecules. So it showed a non-inferior pharmacokinetic property when it compared to IV formulation. The pathological CR rates was comparable, 59.7% versus 59.5%. Pharmacokinetics profile was same. The safety profile was comparable to that of IV formulation. There was also one, the trial also had done a study wherein they asked the patients whether they preferred an IV formulation or a subcutaneous formulation. Obviously, the patient preferred a subcutaneous formulation more as compared to the IV formulation. The patient's preference suggested most of the patients, they preferred a subcutaneous formulation. The healthcare professionals also were very conveniently, they chose subcutaneous formulation over the IV formulation. This was one more trial which suggested the preference of PHESGO over IV formulations or anti-HER2 treatment. Patient satisfaction, more patients were very satisfied with the subcutaneous formulation. Healthcare professionals also suggested that they are more conveniently, they have been using subcutaneous formulation. Safety profile, as I said, no significant safety profile differences in both the arms. So what are the practical considerations for using this molecule in the real world? Now, basically, there are certain precautions that we need to take when we are using this type of molecule. The most important thing that we need to look at is the injection site reactions and the anaphylactic reactions. So basically, it is useful. It is used as a subcutaneous route in the thigh. proper exposure of the area where you need to administer the drug should be done. The best method of using a subcutaneous route is the pinching method. We pinch the area, we angle the injection at a 30-degree angle, and then we administer the drug. We observe the patient for 15 to 20 minutes or 30 minutes, and the duration of time where we should, the time duration should be at least 8 minutes in the first loading dose, and it should be around 5 minutes when we administer the maintenance dose. So if the drug administered if it is administered in the chemotherapy day unit, curtains or other shades are required to ensure patient's privacy. So shorter administration time, 5 to 8 minutes, and observation period of only 15 to 30 minutes, and which reduces the burden of patients, care and providers, healthcare providers. It is less invasive as compared to the IV formulation. So the time duration in which we need to keep the patient in the hospital decreases. Fixed dose formulation can help reduce the risk of dosing errors, reduce the drug wastage, reduce time required for drug preparation and administration with PHESGO, and no new safety signals between the two molecules. PHESGO is the first formulation which has combined two molecular antibodies, and the cycle 7 or the pre-dose cycle 8 trough concentrations will appear to be similar, suggesting similar pharmacokinetics profile, and the pathological CR rates were also comparable. So PHESGO is now FDA and EMA approved for the same indication as IV formulation, Perjeta and Herceptin. Thank you.